Good morning, everyone. Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician at Gatesway Health. Today we're talking about the biology of depression, and we're going to go into some of the underlying causes, so to speak, of this condition, as well as looking at this from a timeline perspective. So we're joined by Kathy. Good morning, Kathy.
Good morning, everyone.
All right, Kathy, and where did we want to start on this subject? I get my models together.
Why don't we start out with the basic question, is depression a chemical problem?
I love it because that's pretty much the mainstream model. That's what we've all been conditioned to think since basically pharmaceutical companies have been allowed to advertise to us. When did that start, Kathy? Was that like 1994 or was that late 90s?
I would have thought it was before then.
I think it was sometime around then because I remember, you know, it was in my formative years and people would laugh about the side effects, you know, because they'd be advertising a medication. They'd have to talk about, well, this side effect and that side effect. And a lot of people said, you know, why would I ever want to take that medication? But clearly there's a reason for them. But nonetheless, I think with the advent of advertising for some of these medications, it's really led to, you know, us thinking that depression is a chemical problem, anxiety is a chemical problem, maybe post-traumatic stress disorder is a chemical problem. And while certainly there is a chemical component, it's not a one-to-one relationship, and it's not as simple as we'd like to think, we being the healthcare community as well as patients. So, and somebody is saying that they're not able to see the video. Well, that's peculiar. So if anyone else has not seen the video, let us know. Otherwise, we'll keep rolling. So that's kind of the opening introduction. Anything else that we had, Kathy?
No, but I've been real interested to hear this because, you know, you and I talked about the chemical issues of it. And as far as timeline, I can remember people talking about Prozac, and we all know I have MTHFR mutation in my genes, but I remember probably late 80s asking for Prozac, actually telling my physician that I needed something because if not, I was going to absolutely kill my husband. and it had to do with my fits of rage, and it had to do, I think, hormones were involved. There were a lot of different things going on, but I just kind of gave him a quick synopsis of my internal feelings when I, you know, became agitated or aggravated with someone or something or whatever circumstance. Immediately, Prozac was written up. I will say this, it did calm me down, but it had a lot of other crappy side effects and really, as we know, didn't address the issues at hand.
Right, exactly. So the issues at hand, what are we exactly getting at? So something that I think is hard for anybody who suffers with depression. Really, what does depression look like? This is someone who is having a lot of trouble finding joy in things that they used to find joy in. They lots of times have this low mood, and it's not a transient thing. So as one of, I think, the foremost researchers in this world, Dr. Robert Sapolsky, would say, you know, depression is a semantic issue. A lot of us say, well, we're depressed because we had a bad day, or, you know, something didn't go our way, so we're down for a couple days. That's not depression. Even if you've lost a loved one and you're down for weeks, that's an understandable consequence of that situation. And so that's not really what we're saying here is clinical depression. Really, clinical depression is someone who goes through something stressful oftentimes, and they go into this low state of mood. And yes, it's longer than a couple weeks, but really lots of times we're talking on the order of months. And they have associated features of not finding pleasure and hobbies or activities. Nothing is making them happy. Lots of times there are associated features of they're losing weight, or they can't sleep, or they feel excessively guilty and they're crying a lot because, you know, they're sad that they said something hurtful to someone 10 years ago. So those are the features of it. Sometimes they have what's called psychomotor retardation, where they just don't have enough energy to get out of bed, and they just can't muster up the energy to do anything. So That's basically depression. I didn't hit all the points, but those are the major points. And so for someone in that circumstance, lots of times, and we'll probably touch back to anxiety in future videos because a lot of our patients have this, but when somebody's depressed, they just wonder, well, why? Why me? Why was I depressed starting in adolescence? What is wrong with me? And that's a frequent question. And we are talking about this from a functional neurology perspective because it's very exciting, the natural aspects and really understanding how one's life leads into somebody feeling depression. What do I mean specifically? Getting into this line of work, I started working with patients who had fibromyalgia, and then I was working with patients who had chronic fatigue syndrome, and then I was working with patients who had irritable bowel syndrome. And as I was going through the literature, there was this common theme that if somebody was exposed to stressful life events early in life, their probability of developing something like fibromyalgia or chronic fatigue or irritable bowel syndrome were incredibly high, much higher than the standard population. So that's kind of intriguing. And then the same holds true for depression and anxiety and things of that nature. So that leads us to say, back to this chemical hypothesis, well, if it's just a chemical problem, how does stress tie in with this? And how did we even come up with the chemical hypothesis? And I know I'm going on a tangent here, Kathy. I'll try and bring it all together. So basically, the chemical hypothesis came from the fact that they were using drugs, correct me if I'm wrong, but I believe they were for blood pressure, and they saw that some of these blood pressure medications had effects on people in their mood because they're affecting neurotransmitter systems in the brain like norepinephrine, dopamine, serotonin. More norepinephrine is really what they're affecting. And so that led them to say, well, maybe if we gave these people medications that boosted norepinephrine, that they would feel better. And that's what they started to see. Or maybe if this is one brain cell and this is another brain cell, maybe if we give this person a medication that keeps more norepinephrine out here between these brain cells, that they'll feel better. And that's what they saw. But as research went on, as drugs like Prozac came onto the market, doctors and researchers soon realized that it wasn't an immediate issue, meaning somebody takes a medication like an MAO inhibitor or a drug like a SSRI inhibitor or SSRI like Prozac, and they don't feel better immediately. Lots of times they'll say it takes weeks. It can take weeks. It can take a month for somebody to feel better. Well, how is that possible? If it's a chemical problem, I should feel better immediately, right? Well, that is a reasonable thought, but it's not quite the case. So then we have to say, okay, so what happened? So here comes the brain model. And I have another diagram here too. So when doctors start looking at the physiology of depression, here's the center of the brain. Deep in the brain, this way in there, is a structure called the amygdala. Many of you have heard us talk about it because it is a central theme to many chronic problems. And so here's our diagram, and gosh, going backwards, okay, we're having success. Right there, see that little almond-like guy? That almond is basically called the amygdala. I say almond because it's about the size of an almond. But that's your amygdala. Right next to it is the memory area. That's called the hippocampus. So your amygdala and hippocampus are right next to each other. Why is that important? Well, something the doctors kept seeing is that in depression patients, their stress hormones were high. So their glucocorticoids, namely cortisol, was way high and it had a hard time coming down. Lots of times they'd inject them with a medication called dexamethasone, and when they would do that, their cortisol would stay high. And usually when you inject dexamethasone into the body, then the cortisol should come down. But in depressed patients, it wasn't coming down. So what researchers found was that this loop between your amygdala, the amygdala fear center would talk to the front part of the brain up here in the hypothalamus. You can't really see it per this diagram, basic area. And then the hypothalamus would send a signal down to the pituitary gland. The pituitary gland would then send a signal down to the adrenal gland. And in doing so, the adrenal glands would make high cortisol, and the cortisol would feed back. And unfortunately, high cortisol, when high chronically, acts as a neurotoxin. So it acts as a toxin to the brain, and it selectively seems to damage the memory area neurons. So that's very important in understanding this physiology of depression. So now we say, okay, this person had a seemingly normal life. They went through this horrible, stressful circumstance. And then when that happened, their hippocampus started to shrink down, so to speak, started to get smaller, so to speak. And so then we have to look at, well, what's going on in that hippocampus? The hippocampus is one of two areas in our brain that makes new brain cells all the time. So we technically make about 700 new brain cells a day in our hippocampus, which is actually phenomenal. You only have two areas in your brain. One is the olfactory bulb, the other is the hippocampus. And so we then have to say, well, if this amygdala, which got turned on by a stressful event, you know, or many stressful events, it got turned on and it's literally dominating the hippocampus to where it's actually growing into the hippocampus. Well, how do we foster new brain cell growth in that hippocampus? And then we found that things like serotonin and norepinephrine and dopamine fuel the neurogenesis in the hippocampus. And that's where these medications come into play. So if you're taking something like a Prozac, which is an SSRI, if you're taking something like Cymbalta, which is an SNRI, serotonin norepinephrine reuptake inhibitor, you're taking something like Wellbutrin, which is going to promote more dopamine in the brain. Those drugs are basically causing your memory area to grow new brain cells, amongst other things. So as that's happening now, the hippocampus can, well, let's say this is the hippocampus, it's going to push back on that fear center. And that can start to reset the cortisol loop, and then that can start to calm down this cortisol effect from poisoning your brain. So then we have to say, well, some people genetically are more predisposed for things like depression, or they seem to be, or some people the depression starts early and why them, and you know, they had a parent with depression, and you know, a twin is more who has depression, their other twin is more likely to have depression, all these statistics. And that's where we get into things like MTHFR, COMT, serotonin polymorphisms, or serotonin transporters. And so today we just wanted to highlight some of that. So how does MTHFR relate to something like depression? What is MTHFR? A lot of you are probably familiar, but we'll go into it. MTHFR stands for an enzyme in the brain called, in the body, methyl tetrahydrofolate reductase. It's a mouthful. And Kathy, anything you want to chime in on there? As I
No, I'll let you say all those big words. You're so good at them, and what you're giving us is just a huge amount of information. So I'm learning like everybody else.
Okay, is this good? Is it like too detailed, too general stuff we talk about all the time?
No, let's spend enough time on each one, and if you can, I know you're trying to cram it all in there, but I think maybe your speed's a little fast for any of us to take notes or get what we need out of it.
Okay, so then also
I guess we can always replay the cast, so not a problem.
Okay, we'll slow down a little bit then. So, in essence, the analogy that many of you have heard me use is that the hippocampus is like a garden. You have your garden, you plowed the soil, it has a nice perimeter. And we want to fertilize the garden. So to fertilize the garden, we want to give the garden, so to speak, things like serotonin, norepinephrine, dopamine. On the perimeter of the garden is a bunch of weeds and blackberries and things like that that are trying to grow in. That's the analogy of the fear center. So in order to make the appropriate fertilizer, we need something like MTHF, methyl tetrahydrofolate, meaning just active vitamin B9. If you don't have active vitamin B9, you cannot make appropriate levels of things like serotonin and dopamine and norepinephrine to a certain extent in your brain cells. So, for example, somebody goes through a stressful circumstance and they don't have an MTHFR problem, their chances of having a relapse of depression is much less, or it's a much greater length of time than someone who has an MTHFR problem. Why? Because if you have an MTHFR issue, then you're not going to have the ability to make these chemicals like serotonin and dopamine as well as someone else, and your hippocampus is going to be more vulnerable to the weeds growing into that garden. Does that make sense, Kathy?
Yes.
Okay.
A lot.
Okay, good. So then basically we can look at something like a SERT polymorphism. What is SERT? Basically it refers to a serotonin transport protein. So perhaps you cannot bring in serotonin into your brain cells as well. So, you know, when I use this analogy of one brain cell talking to another brain cell and we have all these chemicals in between, it's like, as Dr. Sapolsky says, it's like a water balloon. So it's like this neuron throws out a water balloon like serotonin to this neuron, and it receives the water balloon and all the contents inside, and that's how this neuron gets its activation. Okay, so now let's say we have a bunch of serotonin metabolites floating around out here. We want to get those back in to this guy, so he can send another signal to this, to that guy, and this guy can receive it. Well, if you have a serotonin transport protein issue, that can affect the amount of serotonin in this brain cell. Also, these transmembrane proteins for things like serotonin are what the SSRIs work on. So many of you have talked to people with depression. Whether I went to my psychiatrist and they prescribed, Prozac. They prescribed Celexa. They prescribed another drug like Cymbalta, and they tried Effexor, and they're trying Wellbutrin, they're trying this, they're trying that. Why are they doing that? Because the psychiatrist is lots of times just trying to figure out what works for that person, and unfortunately it's not an immediate thing. It may take a month to even know how they're responding. And so that's where now pharmacogenetics and psychopharmacology are really coming into play, where we can genetically test someone and say, well, you lack this transmembrane protein for an SSRI to work on, or you don't have a complete copy of it, so the probabilities of an SSRI working may be diminished. Maybe the doctor wants to try another medication route. Now, in the natural world, we're not dealing with medication, so we're looking at this from a natural perspective. Well, something like St. John's wort may not work as well on you, for example. Or maybe we want to try and foster more 5-HTP synthesis and things like that, which are precursors to serotonin. That's a basic point there. With me, Kathy?
I am, and I'm sitting here, and the only thing that's going through my mind is, yes, when I worked with you and we found the MTHFR gene mutation, then we had lots of answers of where to go. Mm-hmm. I also know people who've been to psychiatrists or psychologists, and they go in, and yes, they give them those prescriptions, but nobody's ever run testing like that. It doesn't exist in the mainstream medical model, and doesn't happen. So like you said, you're throwing Cymbalta, you're throwing Prozac, you're trying this, you're trying that, just to see, maybe throw it at the wall and see if it'll stick to help somebody, rather than finding out what the actual cause is physiology-wise.
100%. And it's all throughout the literature. I mean, it's well known now that basically treatment with antidepressants improves if somebody is assessed for their MTHFR status and they're supplemented with active B9. I mean, it's not that complicated. You need active B9. It is complicated to figure out the right dose. I will say that. But as Kathy is saying, I mean, this information is out there, and that's where we want you to share this information, tell people about it, because it's kind of exciting for anybody who's not getting results. Something like this, something as simple as taking something like B9 that's active can make a big difference for them. And go ahead.
The fact that there are so many versions of MTHFR, mm-hmm. Does that not that has to have something to do with what dosage or what types of the B9 that you're going to give, correct?
Correct. And yeah, there's two main copies of MTHFR. I think there's actually 6, but 2 clinically identifiable varieties of the MTHFR are the 1298C and the C677T. Now, 1298C is basically detox. C677T is more relating to the brain. So when they study MTHFR in depression or MTHFR in anxiety, they're looking at the C677T. Now, so that's a really important point. Thank you, Kathy. So basically in that one study I cited, I can provide it for anybody who wants it. The researchers looked at, I think it was about 166 people or about 150 people who had depression and had traumatic life circumstances, or they didn't have traumatic life circumstances and they had MTHFR issues, or they didn't. And in essence, they found that if you have an MTHFR issue and you have a traumatic life circumstance, the average time from the point of depression to relapse into another depressive episode was like 166 days. If you had the MTHFR issue and I may be butchering the statistics here, and no traumatic circumstance, then it was like 300 days. And then if you basically had no MTHFR issue and a traumatic circumstance, now you're on the order of like 700 days. And then if you didn't have either, you didn't have MTHFR or you didn't have a traumatic circumstance, now you're in the order of like 866 days. So basically you can see that if somebody has trauma and they have something like MTHFR, then that really narrows the window for the chances of them having another relapse into a depressive episode. So it's super important. And MTHFR is just the tip of the iceberg, and there are many, many other components to this. So we talked about SERT polymorphisms. We can talk about COMT. What is COMT? COMT stands for catechol-O-methyltransferase. It's the principal enzyme that breaks down dopamine and norepinephrine in our brain. As simply as we've said in other broadcasts, dopamine is kind of like Goldilocks and oatmeal. Too little dopamine, not good. Too much dopamine, not good. Just the right amount of dopamine is where we want to be in. They say that dopamine follows a U-shaped curve, an inverted U. So if you have too little dopamine, bad, too much dopamine, bad, just the right amount of dopamine, good. And so they've done studies on school-age children, and I feel lucky that I got to see this study when it first came out. I saw it like 4 months before it was actually published. And they went, I think it was in Florida, Kathy. They were in a hurricane zone, and they went to all these school-age children, and they did a cheek swab, and they looked at their COMT genetic status, meaning how are they going to break down dopamine? These kids are likely to incur a stressful event because a hurricane may come by. And so they got their COMT status, and then a hurricane did come through the area. And they were able to predict with 100% certainty, or maybe it was like 97% certainty, it was ridiculous, which kids would get PTSD and which kids would be depressed, just based on how they break down dopamine. Now that point alone is a really, really big thing. So basically, the kids who couldn't break down dopamine, the ones that had too much dopamine, developed PTSD. The ones that broke down dopamine excessively were more likely to get depressed. So it's more complicated than this by a long shot. And we had questions last night about bipolar and genetics. I don't know that I can go into that in this broadcast. I can in others. But when it relates to something like depression, looking at someone's genetics is hugely important. Are your genetics destiny? Not at all. Is a history of trauma destiny? Not at all. And we only bring this up to bring light to the issue, not to belabor the point. But the point is that if you know someone with depression who's not getting better, if you are someone who is depressed and you're looking for answers as to why you're feeling this way, and you just feel like you're weak or something's not right with you, you can't feel that way. You need to hopefully find somebody who can show you the underlying reasons why you're feeling this way, which lots of times relate to things like MTHFR, your ability to break down dopamine excessively or not enough, and your ability to get things like serotonin back into your brain cells. So that's very important. And then, as Kathy and I have discussed, we do brain scans, we do MRI scans where we can literally go in and look at the density of every area of the brain. And we can say, oh, well, your SAD area, which we didn't even talk about today, may be atrophied, or maybe that fear center relative to the memory area, like we were talking about before, and I'll try and get it closer. Maybe your amygdala is literally hypertrophied, and we can show you that relative to your memory area. And on that topic, as we talk about memory and depression, the question came up, well, can this lead to Alzheimer's? And actually, they are saying in some research studies that yes, untreated depression can be a precursor to Alzheimer's. And they're even seen in adolescents, I read a study last night, where they can see that their memory function, an adolescent with depression, is much worse than an adolescent without depression. Why? Because this memory area is so vulnerable to the high cortisol. And we had another question here. Do you recommend that people get genetic testing? Absolutely. Anybody with depression or anxiety, it's something that we look at first. All right, Kathy, your thoughts.
Number one, we know that MTHFR is genetic. Mm-hmm. So if I have it, everyone in my family has it. They don't all believe it, but they do.
They have some level of it, right?
and they don't really, I mean, like everybody else, if you say you have this and it affects your brain or your mental health, then everybody just wants to stick their head in the sand because, okay, that's something I don't want. Mm-hmm. That's a negative in my life.
Right.
But we can very easily change that negative into a positive if we know what we're dealing with. If we don't know what we're dealing with, then you're just kind of sitting there going, okay, no, I'm fine.
Right.
But you're not.
Right.
Yeah. So, I mean, that's the first place to start and to get a handle on it. And whether you're Goldilocks or not, you need to know. Mm-hmm. So, I mean, all of those things come together. I wrote down the line, the brain has a memory for pain, whether that's physical or emotional. We all know that the brain memorizes pain. I mean, if you're a cancer victim, you know it amazingly. That pain comes back, the brain goes, oh, I know what that is, and I'm just going to go with that.
Right.
And that poor person suffers. I think the same thing, tell me I'm wrong, but I think the same thing happens emotionally.
You're absolutely right. And actually, literally the same chemical that goes up in pain syndrome, substance P, goes up in depression too. Inflammation goes up when people are depressed. Exactly. So they call it a psychic pain. That's a great point. Huge point. It's a psychic pain, and that's where some people say depression is actually worse than almost any other condition, because you can't experience any joy, and you're feeling this psychic pain all the time. But keep going, Kathy. Sorry.
Well, I know we're rushed for time, but that's kind of where I've seen it. And since I have seen folks deal with, I think, quite a few of these different things that we talked about this morning, as far as I'm concerned, for what I read, we just touched on the tip of the iceberg.
Right.
So I think next week we need to continue with this and get deeper into the SERT and the COMT and give some people some more info on all of that. And as Dr. Gates says, if you know anybody who feels this way, or you've seen this in a family member or friend, it's not wrong to say, hey, I pass this on. Let them see it. Sometimes people don't want to hear what we have to say.
Right.
But if they hear the doctor saying it, then it's like, okay. And they may not tell you that it reverberated with them, resonated with them, but it may, and it may really help someone deal with whatever it is they're going through.
I love it. I love it. Yeah. And if they want the 18 research articles just from this broadcast that this is based on, be happy to send it to them. So it's all based on the research. I love it, Kathy.
It's not an easy read, I will tell you that.
Right, as we were discussing ahead of time, yeah. Not so simple. Yeah. Okay, and I think we pretty well covered it. The last question we had was about vitamin D and how does seasonal affective disorder play into this. Certainly vitamin D is very important for mood. That hormone needs to be checked in anybody who's depressed. Gosh, we need to even go into, Kathy, things like Hashimoto's and depression and hormonal components. That can be a whole broadcast. So we may be talking about depression and anxiety and all this stuff for a while, but we really want to go into it in depth and give you answers. And any other questions you all have throughout the week, let us know, and we'll try and get that to you. So.
Okay, sounds good.
Okay, awesome. Well, thank you, Kathy. Appreciate it as always.
Thank you.
Yeah. All right, guys. Have a good Wednesday.